we can treat them accordingly. So पंजाबी च कहते हैं बिना गुरु दे गल कीते शुरू नहीं कर सकते. So first of all, मैं गल ही जड़ी है, I have started with the teachers, along with one of my teachers, Satyajit Das, is also on the platform. I would also acknowledge he was the man who ignited the fire in me and brought to this platform. So this was the case of Sardar Ravinder Singh Chahal, and he came to me in the month of March 2025. If I'm not audible, please tell me that there is some network issue at my
You're
side.
pretty much audible. You're pretty much audible.
So through some acquaintance, his sister approached me, Ravinder Chahal's sister approached me for diabetes remission, and after her successful remission, she came to me for this case, and this case was pretty bad in shape. The GFR was 11, and the creatinine was around 6.6 at that time. And his doctor, his physician at Fortis has advised for to arrange extra kidney or go for dialysis. So I was a bit reluctant to take this case initially, but they told me that we are not going to go for dialysis. It is very difficult for us. Let us start with the diet protocol and see whether we can gain something from it. So I use the knowledge which I have acquired from low carb world and from the functional medicine course at Vita One platform, and I start to implementing on this. This person was 47-year-old, as I have given the data. Basically, he was non-vegetarian and was alcoholic from a very young age. At that time, he was taking 2 types of insulin to control his sugar, and these were slow and the fast insulins, and the units are 18 and 18 each. He takes 6 units of fast insulin with every meal and 18 units of slow insulin during the night. He was hypertensive and was on medications. I'll also show you the list. And as I've told you earlier also, that he was suggested for a dialysis or a kidney transplant. And these are some of the chief complaints when he came to me. He was edema all across the body. He usually get breathlessness when he walk or climb up few stairs. He has urinary retention, and he was pretty much big issue for him, this urinary retention. He has lot of fatigue. He was obese at that time. He was having an apple belly at that time, and he was around 97 kg of weight. And he has such chronic constipation that he was on these medications like Dufalac and other medications which are helpful to relieve the constipation. And I think he was taking it daily from last 3 or 4 years and has uncontrolled blood pressure. So as I've told you that doctor prescribed the dialysis, but he was reluctant. As we know that CKD is a progressive disease. It cannot be treated or reversed, but we can manage it. So this is the prescription he brought at that time. He was on these medications. I have, with the help of Dr. Arzu, made some table over here to read the medications clearly. So he is taking around 11 medications at that time. This is the functional timeline. The delivery was normal. He has no major concerns. But in his college, he got addicted to chronic alcohol and opium consumption. And he started to gain weight. He started to get migraines. And at the age of 27 years, he is diagnosed with induced chronic pancreatitis, and then the issue of pancreatitis brought the issue of diabetic mellitus. He became diabetic, hypertensive, and the problems goes on increasing. And at the age of around 44 years, he get AKI, which is the acute kidney injury. So the complications of AKI started. He got edema, he got urinary retention, his medications goes on increasing, and at the age of 25 years the COVID hit him, and he has to be hospitalized for some days. And since then his creatinine was shooting like a rocket, and doctor advised him for the dialysis. These are the physiology and function. He has chronic inflammation, chronic toxin exposure, hypertension, insulin dependent diabetic mellitus, chronic pancreatitis, chronic constipation, and the triggering events was basically alcohol, opium, and consumption of high carb diet, because he was on wheat, chawal, and sweets, whatever there is common food which are made in the house in a Punjab. He's taking all those meats. He's taking corn. He was taking maida and all these things, and he was thinking that I will cover the extra amount of sugar with the insulin, which where he was very wrong. And his lifestyle was sedentary. He don't have any stress because he belonged to a very royal family. There are no financial constraints. The things are pretty settled down, but his sleep was very much disturbed. Almost he sleep only for 4 5 hours a day. That's all. So as per the protocol, the FLR was prepared. Let me show you the biomarkers. So these are the biomarkers. At that time, his glucose fasting was 80, but please keep in mind that he was taking 36 units of insulin at that time. 18 were slow insulin and 18 were fast. And his HbA1c is 5.7, and all was into control due to the high amount of insulin. The creatinine in that report he brought to me was 5.15, but he told me that previously it shoots up to 6.6. His bun was out of control. EGFR was as low as 13. So this is the reason why I was reluctant to start with the case, but when his relatives pressurized me, I took the case. The electrolyte imbalance was there. Sodium potassium values were not in control. The protein was low because his doctor has advised a low protein diet, and the other biomarkers, the calcium absorption was an issue, the phosphorus was very high. So these were the issues with him. So I worked on it, and with the knowledge of functional nutrition and medicine, I could ascertain these 5 issues. There was an issue of methylation. As his B12 was very high, it was crossing 2000. So it is not absorbing in the body. He has chronic inflammation all over the body. His ESR levels were shooting up. And he has insulin dependent diabetes mellitus because he was in a high carb diet. So many nutritional deficiencies. I have just shown you the FLR, and gut dysbiosis because he has high chronic this problem of constipation. So my primary goal was to manage the current symptoms through some changes which are sustainable for a longer time in his lifestyle and nutrition regarding the methylation, nutritional, and the constipation. His iron was also too low. He was microcystic anemic, normocystic anemic. So that was also a concern. So these are the dietary guidelines for insulin dependent diabetic mellitus and CKD. I think I need not to read all the things over here. And you can see, we all know that the high carb diet is not good in the cases where you are taking the insulin. We need to avoid the foods which contains high potassium, high sodium. We need to limit the sugars. We need to moderate the fluid. At that time, he was allowed only 600 to 900 ml or 1 liter at the max of the water intake from his physician. So I make an intervention. I slowly switched him to a low carb diet protocol, and I've put some example, a small example, because I was of the opinion that if we could manage the values of insulin and keep the sugar controlled, keep the blood pressure controlled, there should be an improvement in the condition, and he should do better. So I gave him some protein, very low protein, around 0.6 into his body weight. My focus was onto green veggies, which do not contain the extra electrolytes, and on some energy in the form of MCT oil. And I slowly pushed him towards the ketosis. And these are in lunch. I also gave some low carb roti or some curd or seasonal sabzi, and some MCT oil on daily basis. So you can see around 30 ml of MCT oil he was taking daily orally. So this pushed him, and we checked by the urine diastics that he started to form some ketones into his body, and this gave him extra thrust of energy because he slowly get adapted to fat metabolism instead of the glucose metabolism. So there is a transient shift from these two body fuels. And during this, I used some of the supplements from Vita1 itself, because these were taught in the course, and even Rashi takes so many seminars and discuss about the supplementation and its effect. So for methylation, TMG is very important. So I use homocysteine defense. His vitamin D3 was down, so I use D3 plus K2 combination. Then I use the gastro zinc to plug in the issues in the gastric line, and then to cover for the iron depletion, I give iron bisglycinate, and the name of the supplement is iron complex. I gave a small amount of magnesium. I was fearing that whether he is able to take this much of a magnesium or not, but very happy to say that this much of magnesium doesn't cause any issue. Some omegas, then vitamin C, CoQ10 to have the good fat metabolism. And for sleep, I started melatonin. Initially, I started with the 10 milligram, and then I reduced it to 5 milligram. And I also gave a probiotic from Live Biome. It contains around 18 strains, and 15 billion are the number. And I gave microbiome fiber along with it, so that the effect of probiotic can be long lasting. And the medications were on, as I have shown you, from his doctor at 40s. And I told him that start the work, and after 1 month we can again go to the doctor, go for the test, and see whatever the changes we can have. I also advised him for a lifestyle correction. He lives in a village, so he has a good space around him. So I advised him to start walking for 2 kilometers a day. But initially, he was not able to do it, and around he walked for only 500 meters, and then he got exhausted. But slowly it picked up. Now he walks for 4 kilometers a day. So I also advise some anti-gravity exercise to pull up his muscles and all these things. And sleep got improved by melatonin. He usually now sleep by 11 p.m. and wakes up around 6 or 7 a.m. I refrained him from taking alcohol and opium, but still now I got to know even today that he is taking some of the opium chori chupe. So I got to know today, but he is not taking alcohol. And I've told to monitor his urine input output. Sorry, and because slowly I was in the opinion to increase the water as his urea was high, and I thought that the hydration is low in the cells, so the water should be on the higher side. So symptomatically over the next month the plan was, and the results were, the edema was decreasing in the first 2 months. His constipation was improved. Now he is going for the loo after every 2 days. Earlier it was he was going only after a week. His breathlessness improved, his fatigue get improved, he get active, his pale skin got improved, he gained in energy, which was the chief complaint, and he lost around 10 kgs of weight by that time. And I was monitoring the blood ketones and the ketones in the urines after every month. So these are the last 4 month comparative of the reports in a FLR. So now this is the FLR. The blood sugar is at this point is 111, but please keep in mind that at this time the insulin is only 8 units, which are slow in nature. So the insulin dose decreased from 36 to 8, and the fast insulin, the name of the insulin is Fiasp, is totally obsolete. पूरी बंद हो गई. The creatinine level were almost the same, no change, and the bun was increased by 20 points in the second report. And the GFR also decreased.
Dr. Arvind, can you please show the comparison? So I think they'll get a clarity. Can you just drag it down to the comparison? I think I'll show all the 4 months comparison there.
I think the 4 month comparison is on the next report.
This one, yes. Yeah.
So this is the comparison over the glucose fasting. HbA1c is almost the same. The creatinine values are given here. And the bun was elevated. I told you in the second, this report, the bun was on the higher side. The EGFR reduced further. But the electrolytes were balanced. The electrolytes got balanced during this time. The protein values are slightly low. Calcium is slightly low. The phosphorus was earlier very high, but now the phosphorus started to came into the range. These are the lipid values at that time. The TG was around 108 and the HDL score was 48. So at that time, the TG to HDL ratio was around 2.25. So he was quite insulin resistive at that time. When he came to me, I think his TG by HDL is 3.2, which dropped down to 2.25. His thyroid values were also out of the range. TSH was increasing. But this position also got right after 1 year. I also tested him for any autoimmune condition, because earlier I thought it is a T1 case, but it is not a T1 case. It is the pancreatic damage induced type 2 diabetic mellitus case, which is also known as type C diabetes. His vitamin B, vitamin D were down. Sorry, vitamin B was up because there was a methylation issue. Vitamin D was down. His RBCs were very down, but they slowly picked up. You can see from here 3.47, then 3.64. They slowly picked up. So I will be also showing you the same report, which is currently, sorry, I think,
You need to reshare.
yeah.
Yeah, perfect.
So
Yes, we can see it now. Yeah.
So these were the reports which I want to show you. Now let me come back to the my PPT side. Can you watch the PPT?
Yes,
Yes.
it's visible. It's visible.
So you can escape and put the slideshow on so that the entire screen will come in. So you can escape and slideshow.
Yeah. Thank you, Amarjit.
Thank you.
So by looking at the changes on his body and his energy, his attitude become different. He become active. He was constantly now talking to me. Earlier, his son basically or daughter talks to me that Papa is doing like this, he is doing like this. But when he see a hope, when his body was in his control, he was active, he started to converse on his own. And I asked him whether we can go for some extra fluids because his urea was on a upper side. I want to give him some extra fluids. He agreed, and we increased the fluids gradually and on a constant monitoring what was the output, and the keeping the all the supplements same which I have shown to you. We have also discussed the matter with his physician. He also prescribed the same medication, no changes, and the things went on like this. And the now the condition currently is that he do not have any type of fluid retention, not on eyes, not on face, not on feet, nothing. No swelling, no breathlessness. Even he now walk for 4 to 5 kilometers in his village in the morning, and he has no breathlessness. He is going for a loo after every 1 day, and he has no constipation. I think his gut dysbiosis is improved a lot, and currently he lost 19 kgs. This is data I have put in today, and his BP is controlled, and he has dropped so many BP medications. I think one or two is currently going on. So let me show you the data for July. So I'm going to the comparison directly. Now you can see. Now this glucose fasting is at 8 units of basal insulin. Hemoglobin is A1C is perfect. So glycation is almost gone now. Insulin fasting is a low because his beta cells are not of that side, and you see the creatinine levels now. So slowly, we are into the position that the creatinine reached to 4.5, and I am working on the other parameters, urea and BUN, and we are managing those. Is now EGFR is also increased. He came to me at 11, and now the EGFR is 14. His electrolytes are well balanced now, though his uric acid in this report appears to be slightly above. The protein values have been almost the same. The globulin values have increased. The calcium is still a issue. His liver profile is all well. Bilirubin total, direct, and unconjugated improved. The iron serum is quite noticeable. From 37.2, it is 49.4. It is increased. And the cholesterol values this time, I think this time we don't went for the test for cholesterol. This time we only went for few other parameters because the insulin resistance was decreasing. I was not interested to see the TG to HDL ratio. So we skipped this time. And the HSCRP was 1.6. And RBC you see here 3.64, 3.89, 4.15. So the red blood cells are increasing, and you can see from his face, from yellowness, his face is now turning to redness. So these are the other differential blood markers. Okay, so now let me get back to the medications now. Currently, last week he went to 40s for the meeting with his physician, and he's told the whole story how he get corrected with the diet. His doctor is very happy with his modifications, and he has reduced so many medications. Now he is only these 4 medications are currently in his protocol. Other are the supplements which I have shown to you. So his life is now changed. He is very active. He also sent me his picture today. Let me show you the picture. This is the man now. He was now 20 kg down. The pot belly is absolutely gone. He drives his own jeep on his own. He go for walks. He live an active lifestyle. He is with his kids, and everybody in the family is very happy. So I think this is a miracle with the grace of the people at the platform at Vita One, like Dr. Arzu and Dr. Musa. They have guided people like me. There are many at this platform. They have empowered, they have enabled us to go in the families of other people and help them over their metabolic and chronic issues. And this is the feedback by his daughter. She sent me a video. Amarjit, should I
Yeah,
play the video?
try playing this video. Try playing the video.
Yeah.
So today I'm here to talk about my father reporting. ਜਿਹੜੀ Dr. Arvind ਦੇ patient ਨੇ.
Maybe you can increase the volume if you want to. You can put it on pause, and there's a left button. You can increase the volume. Yeah, if you can.
5-7 years ਤੋਂ ਸੀ ਹੁਣ ਉਹਨਾਂ ਦੀ kidney problem occur
It's all right. Leave it.
2022 ਚ ਉਹਨਾਂ ਨੂੰ COVID. So today I'm here to talk about my father reporting. ਜਿਹੜੀ Dr. Arvind ਦੇ patient ਨੇ.
So she's giving in Punjabi, partially Punjabi feedback.
ਹੋਈ ਸੀ ਜਿਸ ਕਰਕੇ ਉਹਨਾਂ ਦੀ kidney troubled since then, and we've been in touch with his nephrologist from Kotis, Udoto. But since October 24 ਉਹਨਾਂ ਦਾ ਹੁਣ creatinine level ਕਾਫੀ high ਹੋਣ ਲੱਗ ਗਿਆ ਸੀ, and ਸਾਨੂੰ ਹੁਣ ਉਹਨਾਂ ਦੀ body change ਦਿਖਣ ਲੱਗ ਗਿਆ ਸੀ, like energy levels ਬਹੁਤ ਜ਼ਿਆਦਾ drop ਕਰ ਗਏ ਸੀ, nausea, HB level ਬਹੁਤ drop ਕਰ ਗਿਆ ਸੀ, skin ਤੇ paleness ਆਉਣ ਲੱਗ ਗਈ ਸੀ, ਉਸ ਕਰਕੇ ਬਹੁਤ fatigue ਸੀ, ਜ਼ਿਆਦਾ feel ਕਰਨ ਲੱਗ ਗਏ ਸੀ, water retention ਬਹੁਤ ਜ਼ਿਆਦਾ ਹੋਣ ਲੱਗ ਗਈ ਸੀਗੀ, ਜਿਸ ਕਰਕੇ ਹੁਣ creatinine level high ਹੋਣ ਕਰਕੇ food quality ਉਹਨਾਂ ਦੀ nutrition level ਵੀ ਬਹੁਤ drop ਕੀਤਾ ਹੋਇਆ ਸੀ, because protein ਉਹਨਾਂ ਦੀ diet ਚੋਂ proper doctor ਸਾਹਿਬ ਨੇ cut down ਕੀਤਾ ਹੋਇਆ ਸੀ, and water intake ਬਹੁਤ reduce ਕੀਤੀ ਹੋਈ ਸੀਗੀ, and So we were very worried about my father since last year. He was thinking that he could because doctor साहब ने जो further refer करता सीगा for dialysis and for maybe transplant later on. But from our very close family member, we got to know about Dr. Arvind. So actually, Dr. Sarno marched Milia. So the family member they reference to. And इन्होंने मेरे father की पूरी study करने के बाद he gave him a proper diet. He's been on ketosis since March, मेरे father. And उन्होंने काफी sincerely उन्होंने follow किया. So since March, मेरे father की sugar level बिल्कुल stable है. वो 3 times insulin लाਉਂਦੇ ਸੀ. So सिर्फ उन्होंने का rapid चल रहा है. उन्होंने insulin dose बिल्कुल नील है. उन्होंने insulin की dose नहीं करनी. उन्होंने BP की medicine allopathy सी वो उन्होंने हट चुकी है. And उन्होंने almost 12-13 kg weight shed किया जिस करके वो बहुत आगे को light feel करते हैं. He's gained back his energy levels. And उन्होंने face से उन सालों फिर वही glow richness दिखने लगी because उन्होंने उन HP level भी बहुत maintained है. And since उन्होंने जब कि last after 3 months उन्होंने test कराई थी. Another cholesterol, liver reports, thyroid, even HB blood reports, and even creatinine reports have gone much better. क्योंकि whhch blood urea the content बहुत ज़्यादा सी and which has been dropped now. जिस करके वो काफी better feel कर रहे हैं. And बहुत amazing results ने for now till touchwood. And we are hoping that we see much more improvement since now onwards. Everyday routine. He's back to his normal routine and he's taking care of everything. We will be continuing Dr. Arvind's diet for further. And those diet which change that is ki we have seen that my father is able to enjoy his meals, which is very important for quality of life, which he has just recovered. And ਅਸੀਂ ਹੀ hope ਕਰਦੇ ਹਾਂ ਕਿ with each passing day ਉਹ more better ਹੋਵੇ. And we are properly in touch with Dr. Arvind. ਉਹਨਾਂ ਦੀ sugar is very stable now, and creatinine is also under control, and we are hoping it to get much better with each day. And rest of the things are fine and stable for now.
So this was her feedback. She sent me in the month of June when the creatinine starts to drop. Actually, I was not in this thought process that the creatinine will drop down, but the creatinine dropped down. So the whole of the family was very happy. So that's all for my presentation. Thank you to Dr. Musa, Dr. Arzu, and especially Amarjeet for giving me a chance to present this case study among my fellow friends at FMCN Vita One platform. And I'm very happy that you have invited the people who have started doing the foundation course. I will also motivate them and advise them to go and practice the functional medicine because it is the future. The conventional medicine will come to a halt. They will only remain for the surgical procedures. All the other things people will now ask what is the root cause. So the answer is only in the functional medicine domain. Thank you.
What an awesome case there, Dr. Arvind. No doubt about it. It is definitely fascinating. I want to see, did you like the case, by the way? I would love to see reactions. If you really liked what Dr. Arvind has shown, I want to see it on the chat box. And simultaneously, I'll also bring your mentor on the screen, Dr. Arzu. So Dr. Arzu, very, very good evening. How are you doing?
I am much better. Good evening, everybody. Good evening.
Good evening, Dr. Arzu.
Congratulations, Dr. Arvind. I think you presented the case really well. Congratulations on the case presentation.
Thank you, Dr. Arzu. It is all under your guidance that we have been able to crack these type of nuts.
Thank you. Thank you so much. I was just smiling like one of those teachers, was just sitting on the side, very happy that, oh, yes, he's doing so nicely. He's explaining so nicely. He's going along so nicely. So I think that's amazing. I think a big congratulations first, because as Dr. Arvind was saying that, he was reluctant to take the case. I'll be very fair. I was reluctant to take this case even for the presentation, because I would want to put it as a disclaimer for everybody that we know certain chronic conditions are way far beyond functional medicine to manage. But when we are falling to prey of, our own relatives or people who are around who want us to give a try, the idea that we wanted to bring along was not to take these unconventional cases. The idea was to think that how these cases can be broken down into the fundamentals of what you have learned and actually approach those fundamentals, not to achieve maybe a remission of CKD, but to manage all the symptoms that this patient was currently going through and provide them with a better quality of life, more than just putting them onto a dialysis, which they would not be, very upfront. So I think a very good job, I think, Dr. Arvind, on that. I think we've been discussing this case for almost over a month now, and we're going on and on beyond it. But what I would like to suggest is definitely the approach, the rigorousness in terms of doing the reporting, testing over and over again. What I see is a lack of awareness or the lack of conscience when the people happen to take such difficult cases. They think that they can casually manage and leave loose ends in the, portal. But it's very important to talk about basics like, managing urine output, which I think goes unannounced. A lot of people take care of bigger things like managing, insulin with your diet, but managing the urine output and managing things along with it and guiding your patient accordingly regularly. I think that's another thing that I learned through the journey that you did with your patient. So I think congratulations on that. I have nothing, I think, to point out that, this could have been done this way or this could have been done this way. I think, but congratulations, Dr. Arvind. Really well done and very well presented.
Thank you, ma'am. Thank you.
Ada, you are on mute. Yes.
So Dr. Arzu, I was seeing a couple of questions on the chat box, by the way. How are you doing is some of the people are asking. So people who are wondering, by the way, Dr. Arzu got a fracture on her foot and she's been in pain and she is still voted to join in because she didn't want to miss this particular case as well, and has been working closely with Dr. Arvind also for this case. So Dr. Arzu, thank you so much. I hope you're all comfortable and thank you for being so inspiring. So yes, great. We are definitely ready to take questions as well. And I would request everyone to raise their hands. We can help for pain. Great. I think Sinking is telling, get well soon. You're getting a lot of get well soons also as well, Dr. Arzu. So no doubt about it.
Thank you so
you need to be well. We all need to learn stuff. So yes. All right, participants. Questions. Yes, time for questions. I'm pretty sure you might have a couple of questions in your mind. You can raise your hand. The raise hand option is in the react button. You can raise your hand, ask your question in context to the case, and let me put some rules across. One question per person, by the way, okay? So that we can give options to the remaining people to answer to question as well, okay? So we shall be starting off. And yes, another rule, please switch on your video. I don't know. I don't want to talk to a black screen, please. So let's switch on our videos. So Catherine, I request you to please switch on your video. That's when I can put you on screen, please. So we shall be starting off with the questions. Yes, please. Catherine, if you can start your video, I'll put you on screen. Yeah. Okay. All right. Are you able to unmute yourself? Yes. Yes, Catherine, please ask your question.
Okay, my question is, was any ultrasound done? What about the size of the kidneys? And is there any acute illness that was, there was any infection or something in this patient?
Yeah, Catherine, I have a old ultrasound, and the kidney size is quite shrinked, and it also has some cyst into it. There are both the issues. The size is reduced, also he has a cystic kidney.
Okay, so the creatinine came from 11 to 4. From 11
No,
it
no,
came
no.
to 4.
The highest level
No,
of
no, no.
It
creatinine
is
was
stable.
6.6.
Okay.
The highest
So with
creatinine level
this,
rose during his life is 6.6, but when he came to me, it was 5.5.
okay. The only thing is I missed that supplement. What extra supplements you gave? Because you nodosis and Amlong 2.5, along with that 8 units basal insulin, and another one, Revlimid, I suppose, 800 mg thrice a day.
That
That's
are the
Everest.
medications from his physician. I
Medications.
have not
Yeah.
given it.
But from functional medicine, I didn't see. I missed that slide. So, what were the supplements that you were giving? Because I just want to use it for my patients also, because I'm dealing with kidney patients, and I missed that slide. So, if it is about the quality of life, then it will be helpful for
Can
me
I
also.
take this question, Dr. Arvind, please?
Yeah,
Can I
yeah,
take this
please,
question? Yes.
please.
So, Catherine, here I would like to suggest that, see, CKD for this patient was induced because of multiple other complications, like how Dr. Arvind showed in his PPT, that he had pancreatitis, he had, issues in regards to diabetes management, uncontrolled diabetes, hypertension, and eventually CKD. So this hierarchy of symptoms, all the chronology of things that might lead to your patient's AKI or CKD would be very different. So again, what Dr. Arvind tried and did was, CKD was an ant pathology that he was not trying to work at. He was trying to work around the surrounding things that were triggering his CKD conditions as well, which improved the quality of life. So again, it's important to actually make it personalized to your patient and understand what are their root causes that causes their kidney related conditions, rather than following a protocol specifically for supplements. Because if you look at Dr. Arvind's protocol also for supplements, there was nothing specifically given for kidney per se. It was more of a root cause analysis, which was causing the CKD to exacerbate, which was ideally given at that point. So I would say not the supplement, but the approach is something that you need to get in for your patient through what you got into this, entire case presentation.
I hope that answered your question, Catherine.
Yes, it answered. Can I ask one another question if that is
No,
okay?
you have to raise your hand for that. I have to put people
Right,
online.
okay,
Thank you.
Okay, sure.
Thank you, Catherine.
Yes, Dr. Praveen. I have asked you to start your video, please. I would want the videos on. I'm going to the next one. Please switch on your video. Kusum, please ask your question.
Good evening, ma'am. May I speak in Hindi?
Yes, please go ahead.
Hi,
Okay.
Kusum, कैसे हो आप?
एकदम बढ़िया मैम, आप बताइए कैसे हैं?
Good to see you again.
थैंक यू मैम।
Yes.
एक्चुअली मेरे ना माइंड में एक डाउट रहता है, जो किडनी पेशेंट्स होते हैं उनको प्रोटीन देना चाहिए या नहीं देना चाहिए? क्योंकि मुझे ऐसा पता है कि किडनी पेशेंट्स को प्रोटीन नहीं देना चाहिए, लेकिन जब डायलिसिस पे आ जाते हैं उसके बाद प्रोटीन उनके लिए अच्छा होता है। और इसके साथ साथ कितना प्रोटीन देना चाहिए और किस कंडीशन में हम कर सकते हैं? एंड वन मोर थिंग कि उनको डाइट खाने की चीजों में क्या क्या चीजें ऐड करनी चाहिए जो उनको बेनिफिट दें?
Dr. Arvind is the master here then.
Yeah.
Yes, Dr. Arvind, take this up. Yes.
See, proteins are building block of our life. Proteins के बिना काम नहीं चलेगा, प्रोटीन तो देना पड़ेगा। तो मैंने क्या किया इसमें, उनकी बॉडी वेट के 0.6 इंटू ग्राम्स करके जो प्रोटीन था, उनको मैंने कोशिश की उनको प्लांट प्रोटीन देने की, क्योंकि मैंने देखा है कि एनिमल प्रोटीन से थोड़ा यूरिया ज़्यादा बढ़ता है, लेकिन प्लांट प्रोटीन से बढ़िया रहता है। तो वो मैंने उनको प्लांट प्रोटीन पे डाला। हाउएवर उनको क्लास 1 प्रोटीन जो था थ्रू एग्स वगैरह मैंने थोड़ा सा दिया। और जो आप बात कर रहे हैं डायलिसिस के बाद की, तो डायलिसिस में प्रोटीन लॉसेस होते हैं बहुत सारे, आयरन लॉसेस भी होते हैं। तो डायलिसिस के बाद तो फिर एक्स्ट्रा वो देना ही पड़ता है, उसमें फिजिशियन आपका सजेस्ट करेगा आपको इवन उसके आयरन के इंजेक्शन भी लगते हैं और एक्स्ट्रा प्रोटीन खाने को दिया जाता है क्योंकि वो लॉस हो जाता है डायलिसिस में।
तो सर इसकी नॉर्मल रेंज क्या रहती है? 1 ग्राम 1 kg पर ग्राम के अकॉर्डिंग देना चाहिए डायलिसिस के पेशेंट्स को?
0.6
0.6
जी।
आफ्टर डायलिसिस?
नहीं, बिफोर डायलिसिस तो हुआ ही नहीं ना कभी इस पेशेंट का। इसको तो लो प्लांट प्रोटीन के ऊपर रखा है क्योंकि थोड़ा सा प्रोटीन लाइफ की सर्वाइवल के लिए भी चाहिए, अमाइनो एसिड के बिना तो काम नहीं बनेगा।
और सर इसमें वाटर भी रिस्ट्रिक्टेड रहता है ना कुछ, कि वाटर अमाउंट हम ज्यादा नहीं दे सकते?
वाटर इसमें रिस्ट्रिक्टेड था इनका, 1 लीटर से ज्यादा ये ले नहीं सकते थे, 1 से कम ही लेते थे। लेकिन जैसे जैसे इंटरवेंशन की तो चीजें बदलती गई। जैसे डॉक्टर आरजू ने कहा, मैंने किडनी को फोकस नहीं किया, मैंने किडनी के जो ऑल अराउंड कंडीशन थी जो वर्स कर रही थी उसको फोकस किया। और जब ऑल अराउंड का एनवायरनमेंट अच्छा हो गया तो बॉडी के फंक्शन अपने आप ही अच्छे होने लग गए।
और सर
और जो
डाइटरी
लगा
चेंजेस
So Kusum, to
का भी
answer
पूछना
your
चाहूंगी सर।
question on the protein part, I think जो प्रोटीन का बोल रहे थे ना डायलिसिस का, यूजुअली डायलिसिस के बाद प्रोटीन डेफिनेटली डॉक्टर अरविंद ने भी जैसे बोला, यू नीड टू इंक्रीज इट and it can be increased to again 1.2 to 1.5 grams ideally gradually. And second thing जो आपका water intake वाला question था, usually progressively water intake बढ़ता है, and I think there's a formula basically which is कि आपका जितना यूरिन है पेशेंट का उससे 500 ml आपको ग्रेजुअली बढ़ाना है whenever you're treating with a CKD patient यूरिन आउटपुट के हिसाब से. So again, that is a lot of nitty-gritty जो I think nutritionists when they work in hospitals and take care of these CKD specific patients, they learn it there.
Ma'am, what are the dietary changes should be done?
Again, जैसे
क्वेश्चन नेक्स्ट में आएगा आपका। नेक्स्ट
मैम
क्वेश्चन
combined है, ये मेरा combined questions
नेक्स्ट
है।
में जाएगा और डॉक्टर प्रवीण में जाएंगे। ऑल राइट, रह जाते हैं। आई एम रियली सॉरी, आई एम इंटरवीनिंग लाइक दिस, बट यस, पीपल गेट लेफ्ट आउट। सो यस, सीनियर प्रोफेसर डॉक्टर प्रवीण, प्लीज unmute and ask your question, please. I'm waiting for your question. Dr. Praveen, do you have a question? Okay, no question there. I'm going to be putting it down then. Yes, please, Deepak, please ask your question.
Okay.
Yes, we can hear you.
Ask? Okay,
Yeah.
thanks. First of all, thank you, Dr. Arzu and Arvind sir, because I am new to this program and I had been always skeptical as if how can we approach an individual with renal issues, because gut issues, insulin, everything is been covered. But approaching an individual with a renal issue is I had my own doubts. But the previous query wherein Dr. Arzo, you clarified that it's not the renal issue as such per se, but we have to work around the other factors that can lead to the renal problems that we have to address. I've got a couple of queries. Number one, doctor, had this case been undergoing dialysis, would your approach differ? Number one. And number two, why was magnesium supposed to be given in a very limited dosage? These are the couple of queries. That's it.
So, Deepak ji, this person has not gone to the dialysis, though doctor has referred the dialysis from the next month because they approached me in March 2025, and maybe in April, doctor advised the dialysis part. But since they are being on a path where the things were going right, they have dropped the idea of the dialysis, and even doctor now has told there is no need of dialysis. The second thing is that about magnesium, the high dose of magnesium, see, the magnesium has to be cleared by the kidneys itself. So ज़्यादा magnesium I don't want to give. थोड़ा सा magnesium उनकी leg थोड़ा क्योंकि इसका इफेक्ट थोड़ा लेक्सेटिव है और साथ में मैस्कुलर जो है इश्यूज को रिजॉल्व करता है। मैग्नीशियम वैसे भी इट इज अ कंपाउंड विच इज यूज्ड इन सो मेनी बायोकेमिकल रिएक्शंस इनसाइड द बॉडी। सो उसको मैंने देना जरूरी समझा, इसलिए मैंने बहुत लो डोज अराउंड 2 ग्राम्स 1 to 2 grams पर डे रात में उनको पानी में दी।
नहीं सर, मेरा एक वही है कि अगर ये डायलिसिस में होते ऑलरेडी ये केस, तो क्या हमारा अप्रोच चेंज होता है इनके लिए कि यही अप्रोच हम कंटिन्यू करते हैं?
द अप्रोच चेंज होता 100% होता, तो डायलिसिस का पूरा प्रोटोकॉल ध्यान में रख के फिर करते हैं, उसमें चेंज होता है।
In that case, the primary intervention would then be replenishing the nutrition, because if the patient is undergoing dialysis and getting nutritional deficit, which would have been worsening up all the other matrices that you saw, the gut function being worsened up, the hypertension being worsened up. So ideally, it is a case, chronic kidney cases with dialysis is the case of an acute care person, I would say, an interventionalist who is working at the nephrologist level, who is going to guide you on that basis, because then the protocol changes completely.
Yeah.
But answering the second part of your question, would the approach with everything else in the body remain the same? The answer is yes. So I would still be prioritizing, if I'm seeing a dysbiosis coming through gut, still prioritizing that. If I can see there's a high carbohydrate diet, that is why the insulin is so high to control that, then definitely that was going to benefit the kidney function indirectly also. That would benefit the hypertension also. So even if you see this patient, the beneficial signs that you see are not as blood reports primarily that are shining, not as KFTs that are shining, not that significant improvement. But the significant improvement is in terms of patient symptoms, where he's living a better life. And at the same time, the KFT is in a place where it is managed and not increasing. Sometimes in certain cases, things not getting worsen up and maintaining or maybe slightly decreasing are better in chronic cases per se.
So your approach will change. Let's say somebody is undergoing a dialysis maybe twice a week. So
I would not take that patient in first.
Achha.
I would definitely see again, Dr. Arvind ko bhi I think I told him in the first round only, I said that it's a very brave case that you have taken. But again, the approach is something that we need to highlight. It's not, what we need to try and talk in regards to the CKD here is the approach. That is what is the good thing. I would never take a dialysis patient. I would put them to the nephrologist, because hota kya hai, I'll tell you. Somebody who's going to, and this is a very practical tip. Somebody who's been going through an acute care interventionologist every week, maybe dialysis hota hai every month, or maybe gradually dialysis ki frequency badhi jati hai because the kidney is going to progressively get worse.
Right.
So in that case, if you are, and usually conventional protocols are very startlingly different than what we do here. So now there is going to be a patient who is constantly juggling between you as a primary practitioner and the nephrologist there, who are giving completely two different advices. But if he's on dialysis, that's not your patient. That's a patient for an acute care management. We cannot intervene. And ideally, वो case में it's better to take a step back rather than अगर जैसे डॉक्टर अरविंद का कोई केस जैसे आ गया कि नहीं आप मेरा ले ही लो, I want to sit by you, then that's a very tricky case. But practical tip is it creates a lot of chaos between the practitioner, acute care, and we working on the other hand on lifestyle management. Because what you think is also startlingly different in both the ways.
Thank you. Thanks
Thank
a lot.
you. Thank you,
Thank
Deepak.
you.
By the way, Deepak, you are in the FMCN course. Are you in the foundation course?
The FMCN course.
FMCN, the main course, I think.
Are you in the main
May batch.
course?
Yes.
Which
What's
batch
the
are you in?
foundation? The May batch. May.
All right, great, great. You're going to learn a lot, by the way. Good work.
Sure.
What do you do?
I'm a physiotherapist.
All right, great, great. Thanks for asking. Thank you. Okay,
Thank
all
you.
right. Yes, Catherine, please ask your question. Ask your question, please.
Okay. The thing is, it isn't continuing with Deepak. It is related with the dialysis patient because I'm working with both CKD and dialysis patient. And the thing is, why I started doing this course was it is not like the management will differ because acute, yes, for even in dialysis patient they have the stress management is needed, and apart from that, as Dr. Azu told, nutrition replenishment, but along with that energy, we also give levocarnitin, we also give that COQ10. So for those things, I really wanted to know like where the functional medicine stands for these patients, because apart from dialysis, they have so many other complaints also, which I think this functional medicine can attend to. So that is where I want to know. So anything from that side?
So I think the entire protocol, if you look at Dr. Darwin's plan that he has given, has been to support everything. So if you saw, I think you missed that part where he had given CoQ10, where he'd worked because he saw there was a gut dysbiosis also associated with the same patient. He had, issues with constipation. So he supported with microbiome fiber. So again, depending on what your patient has associations with. So if the patient has gut-related issues, then your patient has a gut-related dysbiosis, which is also affecting the inflammation and which could be affecting the indirect inflammation at the level of kidney. Again, this patient had methylation defect. In your patient, it could be there, it could not be there. So treating the methylation defect in certain patients, again, chronic inflammation, increase in the oxidative stress overall, where CoQ10 and certain supplementations work absolutely fine in those cases. So I think supporting what your patient's concerns are, it's not a standard protocol. So if you're telling me your patient had gut issues or your patient had methylation issues, the answer supports that. Got it. I mean, Dr. Arvind, if you have anything to add here.
No, the same. Actually, everything is symptomatic because
And that
we
is
daily
what
have.
functional medicine
Because in
is.
this case, I think on daily basis, I used to talk to him for 30 minutes. From last, say, 4 to 5 months, I'm on daily conversation. We are like friends now. And I know each tidbit of his body, what is happening. He tell me each nitty gritties of the system, each everything, every talk. What is he talking to his wife? What are his kids doing? He is under stress. So these, when you give time to your patient, you get to know what is happening inside, both physically as well as mentally. So you decide on those things, what the protocol we should go for.
I hope that answered your question, Catherine.
Yes.
Thank you.
Thank you.
Yes, Tabassum. Just a minute. Tabassum, please ask your question.
Please unmute.
Yes.
Okay. Hi, good evening.
Very good
Good
evening.
evening.
Hello, doctor. I saw a list of 10 supplements that you had prescribed the patient. So I want to know whether he had any side effects of those supplements that you gave. Because as you said, the water intake was very low. So in that case, shouldn't he be drinking more water to tolerate those supplements? And was he able to tolerate them well?
See, initially the water intake was low, but gradually, when we started the supplements and we increased the water after say 15 or 20 days, we started to increase the water slowly, and we have seen that there is no edema. The edema was going. So I was not afraid of giving the supplements because the things were symptomatically getting correct. The only issue I was facing primarily was of energy and constipation. Those I have addressed with CoQ10. Earlier, I started with the 2 tablets of CoQ10. It is from company named as UNS, and the strength is 300 mg. And I gave the 2 tablets for first 20 days, and then we shift to 1. And we gradually increased the water. His urine output also increased, and we were measuring the urine output, and we were seeing what he was taking, because I used to give him 3 bottles, 3 liters of water, and he can calculate. The bottles were graduated, and he can calculate it from the cylindrical bottles, whatever amount of fluid he's taking. And he's also, we have an instrument where he was measuring what urine he is getting out, and some part we are considering in sweat or in some other things. So as it was not a complication, so I never feared of giving these supplements. Rather, these are all not nutraceuticals. They are not going to hamper in a major way.
Okay, thank you, sir.
Thank you, Tabassum. All right, we'll go to the next one. Rupali, yes, please ask your question. I'm unmuting you. So please don't unmute yourself. Yes. Yeah.
Okay. So this was an amazing case. Actually, with renal problem, it's actually a very difficult thing to always handle. So in continuation with what Tabassum asked actually, yes, for a kidney person, obviously, giving so many supplements together, it's a very big call. So what made you to decide? I mean, how did you take the call?
See, I have shown you the full list of supplements, but they are not started at once.
Yeah, that's what. So what did you give first?
These are
What was the first thing?
all the symptomatic base. The first was I see the methylation issue. So I started with the homocysteine defense. I see low vitamin D. I started with this vitamin D3K2. I see a low iron, and I started with this iron complex, which is iron bisglycinate. So these were the basic supplements. Then he was complaining of this constipation. So I thought of that I should go for some laxative effect. And I know the magnesium citrate has laxative effect. So I started a little bit because I don't want to put extra magnesium. Because in the lecture when I was studying with Dr. Musa, I especially asked this question last year because I was treating a CKD patient at that time. The creatinine was around 3.2. So he forbade me to give the extra magnesium because the kidney may not support the extra form of magnesium. So I started very cautiously, and I see that there was not a considerable change in his constipation. So I shift my attention to microbiome fiber and live biomes. So live biome were 15 billion bacteria, and they need a substrate, and microbiome fiber becomes a substrate where the bacteria can sit down and they can multiply them. And it has a miraculous effect. Within just 3-4 days, he told me that his gut is doing amazing. So I add on the things. When he complained to me about the energy, I put him on the MCT coffee to have some energy. I put him on CoQ10. So the things I planned that I have not planned it on a single basis. I planned it gradually, very gradually. You have seen the complete list.
I think I'll also like to add on to the list here. So if you see as a functional medicine protocol, what we try and do is what you are seeing symptomatically or what you are seeing on your reports, not might be the primary things that you want to start working on. The primary thing has to be what your patient's goal also are in that case. So like Dr. Arvind said that, gradually the goal for the patient, increased, or if he wanted to maybe have more energy or if he wanted to have this. So whenever you're forming a protocol in functional medicine, the foundations are always the basic nutrition that you start with. Irrespective where my patient is coming from, wherever they are, the foundations, the pillars are always, the first floor is going to be all the nutrition correction inside the body. Because simple, when the nutrition is optimized, most of the inflammation that your body cannot manage is taken care of to a certain extent. So if you see Dr. Arvind's plan also, I think there are a lot of maybe 5 to 6 foundational nutrition that to begin with. Then working on what he saw could have triggered the case. So if you saw there was methylation could have triggered. So again, he started with homocysteine for that. What he saw was the patient had gut-related issues that could have triggered the entire case. So he started working on supplementations, not just supplementations, but I would say dietary advices plus lifestyle-related interventions. And then the third happens to be the supplementations that you want to support. So always according to the goals, you set in the foundations and, I think incorporate all the lifestyle related protocols plus the supplementations.
Okay, thank you.
Okay, thank you.
Thanks, Rupali. All right. Yes. So Madhu, you have a question. Yes, please ask your question.
Hello. Good evening,
Hello.
Dr. Arzu.
Good evening.
I hope you are improving, Dr. Arzu. So, very good presentation. I must congratulate you, Dr. Arvind, for this wonderful, very brave step that you have taken. Even I would have really been reluctant to take up this case.
Absolutely.
Thank you, Madhuji. Thank you.
Hats off to you for this. And that gives me a little bit of courage to, take these cases, which I would be avoiding in such cases.
I'm waiting when you're coming to the next case clinic.
We're also waiting for Madhuji to present now.
Yes.
That's a little far away. I've just got my certification today. I passed my test.
Oh, congratulations.
Excellent.
That's great.
So, I don't know. That will be a faraway call. I'm not sure about that. But yes, so just one point I wanted to ask is, You did amazingly well with the weight loss also and the sugar controls. The diet that you mentioned was, just to give one of the sample diets. So that was quite meager. I was just wondering, and for a Punjabi background person, feeling used to so much of eating and, so many times in a day, you just put him on almond flour and then again, no snacks. How did he manage it? What else could you do? Or was it, did you increase it later over the period?
Yeah,
Well,
एक
See,
question तो बनता है डॉक्टर का
a diet for a Punjabi da karan.
so Madhu ji is तरह है कि I agree with you, but at that time that time is very crunchy. When patient come to you, my office is around 2 stories above, and I know his son and daughter. He fetch him, and slowly he take 15 minutes to get to my office, and he was like this. The whole of the face was swelled. The eyes from this side were swelled. He was quite high edema. So at that time, the question is of life and death, because you have came from the hospital. Doctor has told you, the family, pick up your bags. You have to come to the hospital. You need to stay here. You are going for dialysis. So, zindagi de maut da question hove.
So that motivated him to stick to your
Yeah.
diet. No, but seriously, what I want to ask is whether did he say that he's hungry, or did he feels hungry, or he had lost his appetite?
Yes. He feels hungry initially because there was an insulin jumping. So he has hunger pangs, but slowly, when I put him into the ketosis, when he enters the ketosis,
Okay.
immediately hunger pangs go away. The fourth fuel has generated.
So you monitoring for the ketone bodies?
Yeah. I was doing the blood test for ketones. I was doing the urine diastase test. So immediately hunger pangs goes away. Now today he was having moong ki dal and almond flour roti. Today he had, and he is enjoying. So I am now starting to give some of the moderate carby meals.
Basically, you had omitted gluten, wheat from his diet. But did you add rice or brown rice on here? Because
not yet.
Not yet.
Not yet.
Only on
I am planning to do. I am planning to see. Actually, I started my metabolic field from Dr. Eric Berg in 2014. So I am an admirer of a ketogenic diet. So I think carbohydrates are redundant food, in my personal opinion. This is my personal opinion. I'm not imposing it on everybody. I neither take carbohydrate myself, nor I advise to anybody. Still,
I'll add on some important thing. There is a story behind this case clinic as well. By the way, in the month of, we were supposed to meet Dr. Arvind in the month of June. Am I right? Dr. Arzu, Dr. Arvind.
Yeah.
So what exactly happened was Dr. Arvind, a virus came and met him probably in the clinic and he got that. And then you had to be on, you were recommended antibiotics, but Dr. Arvind has been without antibiotics for the past, how many years? 15 years?
Around, yeah.
He has not had antibiotics at all. And he told me, no, I need this much time so that I can present my case properly. And I said, okay, fine, not a problem. We will definitely adjust accordingly. We want to see your case. And you can see him now. I don't think I need to explain whether he needs antibiotics or not. So he has not been taking antibiotics. He himself is a very big idol for all this. He follows what he's talking. He practices what he preaches. So pretty much very admirable there, Dr. Arvind. Very good done there.
Congratulations once again. Very good. Thank you.
Madhuji.
Thank you.
Thank you. All right. Anuja, you want to ask a question? Yes, please ask your question.
Thank you. Thank you so much for the session. I missed initial portions of it, but most of the questions were asked, and I got I think I'm good with. But I have a off-road question about kidney stones. Several clients I know have kidney stones, and it keeps repeating once in 6 or 9 years, and despite them shifting to more balanced macronutrients, still they are saying they're getting it. So there are several stories that I've read, but nothing very convincing about the root cause of kidney stones.
I will say, get one of your reports, one of your patients, get their, the histopath done with the kidney stones if it is surgically. I would say 90% of the patients, when they get their histopathology report done for the stone analysis, when they get it done, it's usually a calcium carbonate stones. Now, calcium, even if you're not eating, it's because of gradual decrease in magnesium overall inside the diet that has been there because of the lifestyle related intervention, the soil depletion in magnesium. So people who do not have enough magnesium through supplementations or through, topping up through their diet, what happens is, and you cannot actually replenish magnesium through diet. What happens is the counterpart of magnesium, we all know calcium and magnesium, they run as a synergy, the action potential. The magnesium, if it is low, the calcium intracellularly goes and affects. Now, the results are not only stones, but they're even causing, sclerosis-related issues, the CVD-related issues, cardiac complications. The plaques are usually calcium deposits, if you see in those. When patients get their, the artery angiography done and they get the calcium score also, that's again extra calcium decisions. So I would say it's most probably extra calcium because of magnesium that causes this kidney stone pathology also frequently, if it is very frequent. So by keeping your patients or your clients on a higher magnesium diet, higher magnesium through supplementations, and a baseline, keep checking their calcium ionized and keep checking their calcium and magnesium ratio overall.
Calcium magnesium ratio. Is there a particular range that we
No,
need to maintain, doctor?
I would say for magnesium, somehow try to be in the optimal range of 2 to 2.5, for calcium, somewhere around 9.5 to 10. If both of these are in the, and this is all Ng by ml, if both of these are in this constant ranges and they're in the same ranges, you don't have to worry about it. Either of the parameter above or low, it will only suggest magnesium deficiency per se, until and unless your patient is an old geriatric patient or a menopausal women who might have calcium metabolism issue. Most probably disturbance in calcium and magnesium are magnesium deficiencies. And when you give magnesium, both of the ratios get balanced overall.
Okay. Okay. That's
Can
great.
I extend this question?
Yeah.
Yeah, Dr. Arzu, some people have this oxalate stones. What is the story?
Capsule. See, again, those are through the stones. Whenever you eat oxalate inside our diet, it increases. Oxalate stones be dietary through interventions ही है. But I would say ये जो recurring stones होते हैं ना, these are 90% calcium. Oxalate is again diet mediated, through that you cannot control. There's no preventive mechanism that you can do for what comes through your diet. But for calcium related pathologies, I think I would say 85 to 90%, because initially in my practice, I've done this. If anybody is coming, I would be like, okay, send me a histopath report. Pehle ka hai, baad ka hai, kya hai? But it has turned out to be calcium carbonate stones.
Got it.
I hope that answered your question, Anuja.
Yes, absolutely. Thank you so much.
Thank you.
Thanks, Anuja.
All right. A little announcement for everyone, by the way. If you are wondering how are we actually talking about all of this and how did Dr. Arvind actually magically do all this stuff in his case, it happened through his course called FMCN, Functional Medicine in Clinical Nutrition course. If you are wondering and you are not registered for this course, and by the way, all the FMCN students as well, if you have referrals, this is a good time to give because we are offering good discounts. Okay, get your friends along, get your colleagues along. We are ready to get them in. Yes, let's make difference to the world all together. Yes, because we know functional medicine is the future. All right. So yes, anybody who's looking in whom to contact, please contact Asma in the team. She is from Vita One team. So ASMA, she is putting in a message on the chat box. All right, let's go into the next questions. And by the way, we'll also be mindful about the time as well, because I wouldn't want to extend the time. So please put in single questions, okay? So, and please don't ask me to ask you to switch on your videos. I don't want to talk to a screen. I want to take a photo. Come on. I want to make you famous. Anyway, Anuja is done, I believe. Anuja has done. Kusum, yes, please. पूछिए जी, अपना प्रश्न पूछिए.
थैंक यू मैम. मेरा वही प्रश्न है कि खाने में क्या क्या चीजें चेंज करते हैं. डाइटरी पैटर्न का पूछना चाह रही थी मैं, जो लोग डायलिसिस पे हैं या डायलिसिस पे नहीं भी हैं, बिफोर डायलिसिस एंड आफ्टर डायलिसिस, क्या उनके फूड में चेंजेस रहते हैं? थोड़ा सा उसके बारे में। एक तो मैग्नीशियम का आपने बताया मुझे, जो समझ में आया।
कुसुम जी, मैं फिर से वही बात दोहराना चाहूँगा, ये हर आदमी के सिम्पटम के ऊपर है। कई लोगों को डायबिटीज़ नहीं होती है, हाइपरटेंशन की वजह से किडनी डैमेज होता है। कई लोगों को हाइपरटेंशन होता है, डायबिटीज़ होता है, उसकी वजह से होता है। कईयों को कोई टॉक्सिन इश्यूज़ की वजह से होता है। तो देखना पड़ेगा इश्यू क्या है, ये थोड़ा इंडिविजुअलाइज़ अप्रोच रहेगी, इसको एक मॉडल बना के अप्लाई मत कीजिए। इसके बारे में थोड़ा जानकर करके फिर कीजिए। मेरा जो इस कॉन्सेप्ट में मुझे लो कार्ब करना पड़ा, क्योंकि वो इंसुलिन ले रहे थे और मुझे मालूम था इतनी हाई इंसुलिन बॉडी में अच्छी नहीं है। इंसुलिन इज अ फैट स्टोरिंग हार्मोन, तो उनका वेट बढ़ता जा रहा था, तो मुझे वो इंटरवेंशन करना पड़ा, लो कार्ब पे लाना पड़ा। हाइपरटेंशन के लिए मुझे फैटी लिवर का भी करना पड़ा, तो फैटी लिवर जैसे जैसे कम हुआ उनका, तो हाइपरटेंशन भी उनका इंप्रूव हो रहा है, और आने वाले समय में मुझे लगता है कि बिना दवाई के अगर चल जाए तो बहुत बढ़िया है।
Okay. So I think what I've understood is I'll give you a basic idea. कुसुम जी के क्या करना चाहिए अगर आपके पास एक बेसिक सीकेडी का पेशेंट आ रहा है. There are basic things definitely you want to cut down on, जो डॉक्टर अरविंद ने भी किया था, और उन्होंने एक गाइडलाइन शेयर किया है अपने प्रेजेंटेशन में. So we will be sharing you the entire guideline for sure. But simply, अगर CKD का patient है per se, and we're thinking about kidney only, basic sodium restrictions, phosphorus restrictions inside the food, खाने में जिसमें ज़्यादा sodium phosphorus है वो avoid करना है, तो fluid restriction करना है, that is very important. So again, there's a lot, because managing CKD cases, if you see, these are actually patients who are managing most probably with a nutritionist at a hospital. So ये बहुत ही ज्यादा थोड़ा क्रिटिकल हो जाता है फॉर द फैक्ट बिकॉज द फ्लूइड रिस्ट्रिक्शंस की वजह से यू डू नॉट नो, पानी आप दे रहे हो दवाई के साथ वो भी पानी पानी गिना जाता है. सो अगेन इट्स अ वेरी आई थिंक एक्सटेंसिव वे टू लर्न इट, बट जो हमारे पास बेसिक गाइडलाइन डॉक्टर अरविंद ने शेयर किया है, वी विल शेयर दैट विथ यू.
थैंक यू,
Okay.
थैंक यू, थैंक यू.
Yes,
All right,
yes.
और एक और
Okay.
चीज, आई थिंक आप बीच में हो अपने कोर्स के, कुसुम जी. So just like you, by the way, initially you learn in batches and then you become a part of the alumni after certification. That is why एक webinar में सारे answers नहीं मिल पाते हैं. By the way, I want you to understand कि all cases are unique. Every single person you deal with is unique. उसका एक unique customized approach. That is functional medicine. Okay, so ensure that आप एक दूसरे के साथ दोस्ती बनाए रखें. Keep in touch with your colleagues. That's the reason we are putting all of this. These are things, these are events that are organized for you. अपने दोस्त बनाइए. Find out whom you can click with. Dr. Arvind clicked with Low Carb of Dr. Eric Berg, and that is why it's his USP, how he deals with his patients. It may not be your USP, but yes, you can learn from each other and एक दूसरे से बात भी कर सकते हो. By the way, we don't restrict you like I am restricting you. यहाँ पे बंद कर दिया बोलना, नहीं होता है ये on your alumni group. Okay,
And
jokes
also,
apart.
I think one very
Yeah.
good thing that we actually came across is we went through an offline conference very recently,
Yeah.
where we had our FMC and alumni meeting each other for the first time, and they were like, "Oh, we are friends from this batch. Oh, we are friends from this batch." It was a very overwhelming feeling जब बहुत सारे लोग पहली बार live मिल रहे हैं. It was a great feeling for us also, I think, in that way. So the idea is make the community strong, know who you are working with, know who's studying with you, know आपके contemporaries कैसे cases handle कर रहे हैं. So when we require that prompt help, maybe at that point जब आप नहीं कर पा रहे हो, there will be somebody waiting for you to take your case right up or help you with those cases also as a part of the community.
I hope that made it clear, Kusumji. And this is an information for everyone, by the way. Okay.
Yeah, absolutely.
So, yes, let's go to the next question. By the way, yes, Dr. Pratibha, you can switch on your video so that I can bring you on stage, please. Yes, please ask your question. Yes.
Can you hear me?
Yes, we can hear you.
Yes.
Yeah, so hi everyone, I'm Dr. Pratibha. So I wanted to ask this to Dr. Arzu. Thank you, Doctor, for your presentation. Doctor, you presented it very nicely, Dr. Arvind, and it was a really complex case. I myself is a diabetologist. I practice in Mumbai. So I deal with many cases who have CKD, early CKD, who have just started and who are on insulin. So I wanted to ask about berberine. So I'm scared to use it in patients who are on insulin and showing early signs of CKD, because I've been using it on people who are on OHs and they are showing very good results. So I just wanted to know, can I use it in early CKD patients? So how is it? Can you just show light on it? कि
I
कैसा रहता है?
think, in my opinion, we can use it.
Absolutely. See, berberine has strong clinical research in terms of increasing the insulin sensitivity. Plus, it also works as an antimicrobial in terms of putting down the inflammation also. So again, whenever you are taking any supplements, I'll also suggest any supplements will not cause major effects in terms of putting the blood sugar down. Same as the result with berberine. So you will see there will be a gradual shift in the sensitivity of insulin over time
Yes.
is what you will
Yeah.
see, rather
Yeah.
than a patient going into hypoglycemia after taking berberine.
Yeah.
Since these are already plant-based supplements, you start with smaller dosages. Again, ideally, if your patient is on a lot of medications, try doing, a lot of interventions, check with them, check their reports. I would say it will gradually do those changes. Nothing will happen overnight. So you can safely give berberine also if
That's
your
what I
patient
wanted to
has
ask.
diabetes.
To make, because patients are insulin resistant or insulin, so I want to increase their insulin sensitivity. So, but I was afraid to use in patient with CKD because their EGFR might decrease and they come hitting my head, what you've given, what you have done. So I was a
No.
bit
Thank you.
skeptical to use it.
Even from my last discussions, I am also starting Dialer Plus from next Monday to the same patient, which is combo of fenugreek, cinnamon, and berberine, chromium
So
picolinate.
it's by this company called Live Bio. They make an entire
I'm giving from
blend.
Monday because his insulin resistance have dropped quite a bit. From 36 unit, he has come to this 8 units only. So I was trying that if we could avoid the insulin, but his C peptide is quite low. So I'm just trying to get down to more 4 units we can drop. That's it.
See, for this patient also, because he's a chronic pancreatitis alcohol-induced patient, maybe the insulin might never go. Maybe it will go on baseline once we manage the diet accordingly. But again, this Live Bio is a brand by Dr. T, and he has a Amarjit, what is Dr. T's full name?
Dr.
Dr.
Thangadurai.
Thangadurai. Yeah, I remember him as Dr. T only. It's a brand called Dr. Gold Live Bio brand hai. It is a overall supplementation which is natural ingredients like Dr. Arvind just mentioned, berberine, fenugreek, there's cinnamon, there's ALA along in it. It is very good for diabetic patients per se.
And it is available on Vitavan website.
Okay,
All
okay.
right.
Thank you. I will definitely
Thank
try
you.
it. And
Sure.
then definitely will let you know in other case.
Sure.
there's
And also it has
Yes.
chromium also, I think. And chromium is very good for insulin sensitivity. The Dialol Plus.
Yeah. 200 mcg of chromium picolinate.
Yeah.
Thank
Dr.
you
Arvind
so
knows
much.
the entire composition because he's planning to give it right now.
Thank you so much. Thank you,
Thank
Dr.
you.
Okay.
Thank you, Dr.
Thank you. Thank you.
Thank you. Yes. Dr. K, I'm not sure how to call you, but yes, please.
Dr. Krishna, actually, KSS Krishna, actually, my name.
Yes, Dr. Krishna, please go ahead.
Sir, first I would like to congratulate Dr. Arvind sir and Dr. Arjun madam.
Thank you.
One small request to Vitavan, actually. We are finding very challenging to attend these sections at this time, actually. Currently scheduled time, basically it will be OP time for many of the physicians, sir. So I sincerely request, we wish to participate in live sessions, but the time is confronting actually to all of us practitioners. So can you please reschedule to, in consideration of all practitioners, if you do in some other time slot, it will be beneficial for all of us. Just a small request. I wish to congratulate both of you for dealing
All
such
right.
a
This
you.
request was
Thank
for
you.
me, I think. Okay, fine.
Yeah.
So I
To
was
whom,
wondering. Thank you.
to
Thank you for
whomsoever it may
informing.
concern,
Thank
just
you.
please
Thank you,
kindly.
Dr.
Every
Krishna.
time it's getting the same problem we are facing, actually, the
All
clinic
right.
timings.
All right. All right. And are you a FMCN practitioner?
Yeah, recently I
All
have
right.
joined the July
You have
batch,
recently
actually.
joined. Just hold on
July
there.
batch I have.
You have a continuing functional medicine education folder. These are sessions which are recorded, and I'm pretty sure everyone misses it out. Continuing functional medicine education folder has all of these recordings which are given to you for sure. So you will not miss them out. Another thing, These events are planned keeping in mind multiple people's schedules. So Dr. Arvind has a schedule, Dr. Arzu has a schedule, we have a schedule, my team has a schedule. That's how it happens. So do not worry. If you get stuck anywhere, the folder is there. Contact Maumita. Maumita is going to be your buddy there, who's going to help you out. Okay. So do not hesitate to ask these questions. It's a wonderful question. I'm very thankful to you for telling me. This is feedback. But yes, as much as possible, we'll try to do things at an appropriate time and an appropriate day. But yes, we always ensure that you get the recordings as well. Okay.
Thank you. Thank you.
Thank you.
Thank you.
All right. Poonam, yes, please ask your question. Just give me a minute. Ask your question, please.
Yeah, hi. Good evening, Dr. Arvind, and good evening, Dr. Arzu. It was a wonderful session. Okay, so this is regarding insulin resistance and usage of keto diet. So basically, I was interested to understand that for diabetic patients and who have like uncontrolled diabetes and on high insulin, so keto diet always work as per you. And for how long we have to keep them on keto diet? Will it be lifelong, or after some time we will start like we can get back to a normal diet, which I say, which has, some good percentage of carbs and fats and protein. But in keto diet, basically you are giving more of the fat, like the highest percentage of fat and then protein.
I can bifurcate your question into two parts. There are two types of patients who are early diabetes, say 3-4 years. So they have some mitochondrial insufficiency, and if we put them on fat adaptation, lower the carbohydrates, I have seen people have reversed completely. So I think I have not checked, their insulin resistance dropped, they improved their mitochondrial issues, and they completely reversed their diabetes. And I cautiously forbid them, because I've already told you, I think carbs are redundant. In my protocol, they are not present. So, but people used to have the thing, so I don't want to take up their taste. My philosophy is food for fuel and not for taste. But everybody don't have the same philosophy. So people used to take, and I tell them to take that much gram only. And they make it a lifestyle. They don't be fat adapted enough, but they will be on the low carb protocol. So these type of issues doesn't come. And the second type of cases are where the beta cell are almost exhausted. So
The C-peptide.
yeah, say the C-peptide maybe 1.2, 1.3, but the beta cell exhaustion is there, and people are on the glimepiride, glycide type of salts to push the cells to make more insulin. So there is a fight between insulin and glucagon always. So to those people, I advise to make it a lifestyle, because now the insulin is down. So the management of glucose regulation is difficult. So better to go to keto and make it a lifestyle. I am on ketogenic diet from last 7 years. I don't have diabetes. I don't have blood pressure. I have nothing. And in my family, the things are there. So I think ketogenic diet is a way of living.
I think I'll add my way of living out in that case. See, like Dr. Arvind also said that, it's also very patient, I would say practitioner-centric protocol that people choose by. So I'll tell you what we in general also do, and we definitely when we push them to the keto part of it, because we maintain a practice where we are not able to actually get in touch very regularly with the patients. Maybe they come with us and maybe the interventions are not as regular in terms of as a doctor. So what we try and do is we don't start them with a very low carbohydrate diet, maybe somewhere moderate to low is where we put them at. And like he said, increasing the fats is one of the major goals that we also started, and increasing the protein. So the only thing we start to reduce gradually is, the carbohydrates to maybe a moderate to low kind of an, maybe somewhere around 120 grams or 150 grams to begin with. And as they maybe improve, maybe we can keep it at the same or gradually decrease it also. It depends especially on the patient. But the fundamentals of you need to increase the good fats, increase into the quantity of maybe even 40 to 50 ml per day to them, and eventually increasing good proteins to a stage where it is 1 to 1.2 grams in a normal healthy individual who can take the proteins. This should be your ideology. And then carbs management in terms of how you want to push it further should be taken. But a no negotiable thing is increasing the protein and the fats as we discussed.
Okay, so this type of management, like increasing fat, increasing protein, and keeping carbohydrate like fit to what is required, this approach should be there for treating most of the cases, right? Whether it's diabetes, whether it's thyroid or gut issues. So it will be similar approach will be there for most of the cases.
I wouldn't agree to that. See, again,
Okay.
for gut-related cases, depending on what their problem is, there's a low FODMAP diet, there is elimination diet, there's extreme elimination diet. For thyroid, again, if it is an autoimmune thyroid, which is Hashimoto's, it would not be just a carb management, but managing of certain allergens, also eliminating certain foods. So I would say it's not the same. But a low carbohydrate and increase in fat and protein is a general way of lifestyle. Again, depending wo carbs kitna low hona chahiye is patient centric. If the patient is coming at 6.5% of HbA1c, then definitely we know that the carb can be not put to such maybe lower. Maybe you can still start at 150, 150. But if the same patient came with 11% of HbA1c, the management would be different even if he's on oral diabetic medication or insulin in that case. So again, patient-centric, and all these conditions, thyroid, gut-related issues, they have specific diets that you need to go on. The fundamentals are obviously about maintaining the proteins and fats, as we know about any healthy being also.
I hope that answered your question.
Yes, yes, definitely.
Thank you. All right. We shall be coming to the last question. Please ask your question, Anuja. You're back.
Thank you. Thank you so much. So few of the CKD clients do have varicose veins, painful. So is it related or was it how do you look at this?
See, the varicose veins is also a consequence of IR, insulin resistance. So the story goes long away. First you have IR, then you have diabetes, you have fatty livers, then the issue is with the nephrotic cells, then you have AKI and so on. So
it's a sequence continuum of things, even when you look at varicose veins per se. So again, it's nothing but eventually your veins not being able to pump up the blood. And there are multiple causalities to it, as simple as maybe severe magnesium deficiency. I'm sorry, I keep coming back to magnesium. But since I just want to say that there's multiple things that can be contributed, as simple as nutrition like magnesium, or maybe like Dr. Arvind said, the insulin resistance, or in certain patients of complications of CKD also as in general. But it's all a web. You need to think multiple things causing multiple things. So I can't give this is causing this kind of an answer.
Right. I agree, because I read an article that says copper deficiency as a reason for varicose veins. So just wanted to check if there is any experience on your side.
See, again, there's a lot of causations and correlations that are not well put up in terms of articles also. They put in the correlations N to N, A is equals to Z. But again, A is equals to Z is not possible because there are multiple variables in between. So again, I would say the articles always, depending on what material you read, where it is coming from, what is the citation, how much you can trust, where to read from is all also very important.
Yes, yes,
True.
yes. I totally agree with Dr. Arzu, and that's the reason I want everyone to know. This is the reason we have partnered with the Institute of Functional Medicine US. That's the gold standard. Okay. What we teach you is from the gold standard. And that's the reason the FLR system was launched for you, so that you can correlate everything. It's not one-on-one. It's not 1 and 0.
Right.
This is happening. This is happening. So utilize the, I think Dr. Arvind would like to say how the timeline has changed the way he is going to approach people now. So Dr. Arzu and Dr. Arvind were all this timeline. They were creating this timeline for this particular patient. Dr. Arvind, I want you to speak on this, because how making a timeline has changed the face for you, the way you deal with everyone.
I am not a tech savvy person, and I was jotting down all the things over there, and Dr. Arzu was instrumental. She did the job for me. I'm so glad, so thankful to her. She's very humble. She guided me that give it to me that I'll do all these things from my team, and I have learned how the things are gradually changing from a lower age to the higher age, how the things are moving in a continuous manner, and you can draw so much of inference from that timeline.
How it has changed your approach now onwards after doing this particular
Yes.
case on the case clinic?
After doing, I'm doing it from the first day. Today I have signed 2 cases. I'll be doing from the very first day. I will be making the timelines.
Perfect, perfect, fantastic. And how is the FLR helping you out?
Wonderful. After FLR, everything changed. Now I look at the ratios. The things are in a ready-made possession for me. Earlier I was writing, I was doing on the calculator TG2H litna aa raha hai, I was going to the Fulani site and all these things. Now everything is ready-made. All the because ratios are very important.
Important, yeah.
So you can see what is happening inside and what intervention you need that is coming from the ratios itself. So it's a wonderful, wonderful job. That's why before I starting, I thanked both of the mentors, Dr. Musa and Dr. Arzu, because I never missed your classes.
Great to know that, Dr. Arvind. And yes, no doubt about it. I want to tell everyone that, Dr. Arvind has also been a student just like you. And that's the reason this particular platform has been created only for you, so that even you can learn, grow, show what you're doing, because I know all of you are doing great stuff. Okay. By the way, I didn't raise my hand. I'm going to raise my hand because I have a question. So my question was, the vitamin B12 in the report was extremely high. How did you recommend homocysteine defense? Weren't you reluctant to give it because even homocysteine defense has vitamin B12?
See, the kidney patients usually have B12 high because B12 is in the blood. Kidneys are not going to use it, but they have methylation defect. So for TMG, I use the homocysteine defense and not for B12.
So did it affect the B12 later on?
Yeah, we are going to check the homocysteine now next month, and I'll let you know. I think there must be some improvement.
So I think that initial report did have a little change in the methylation, and usually is the recirculation whenever it's very high. There are multiple causes of the recirculation. Again, it could be gut dysbiosis to like how Dr. Arvind mentioned, even, CKD related issues for sure. So in those patients, rightly checking the homocysteine, I think, which I had written down in my own notes because Dr. Arvind, I think he forgot to mention it there. This patient came with a very high methylation when he tested this first. So it was somewhere around 49, 50 at that point, with even that much high of a B12 and a lower B9 correlated with it.
Yeah.
So I think that's an eye opener, and people who are into FMCN, they know how much we talk about methylation in all the cases with multiple modalities again. So I think that's an eye opener again, that just B9 high and B12 high with homocysteine elevated is homocysteine defense works the cure for that.
I think the raised hands will keep continuing. Now I'm only going to ask the permission from Dr. Arzu and Dr. Arvind, whether you want to take 2 questions, because I'm not going to take any further questions. We need to be mindful about the timings. It was still 7:30, by the way. So, and I already indicated that Dr. Arzu is in a recuperating phase. She's just cooperating with us. She cannot be sitting for this long. So yes, questions, Dr. Arvind, Dr. Arzu, I leave it to you, by the way. 2 questions have popped in.
See, I think I will not sleep well peacefully if I see 2 hands going and not answering the questions. This has been my problem. That is why my sessions last until 9 p.m. some days.
So the same. When we have the classes with Dr. Musa, the sessions sometimes start at 9 and goes up to 9:30, 10.
Nah, it doesn't start at 9. It starts at 6. It starts at 6. It starts at 6.
And
yes,
and we
it'll go forever.
We are the following the footsteps, so we never say no.
If it is methylation, it'll go forever.
No, and I think
the teachers have set the culture.
No, I think also I would want to put that up, that if you see the entire organization, I think anybody who we get into the organization also, we tell them that you're here to serve, you're here to help. We're not here to generate anything out of this. So if this session will leave to queries unanswered will maybe leave this unpurposeful for some people who have joined in. So we want to spread in the knowledge, and that is why we want to keep doing this for making that difference to all participants as well.
I think that deserves appreciation. I'm going to give a heart there for sure. So yes, thank you so much, Dr. Arzi. That's the reason we all love it. Yes, Poonam ji, ask your question, please.
Yeah, so this question is related to homocysteine only because, as you were discussing. So my case is like sometimes like people have been taking B12 supplements, like general supplements like Neurobion, Forte and all, and B12 is coming in 800 kind of range. But there are other issues like lipid profile is not good and homocysteine is fine. It's within the range. But then what should be our approach? Homocysteine defense we will be giving to that person, or we will be giving or we will not giving any kind of B12 like active folate तो देने का कुछ फायदा नहीं है because it's already उनका B12 higher range में है. So what should be our approach in that case?
So you're saying that the B12 is in a higher range, you've not checked the B9, and homocysteine is normal or elevated?
It's normal.
Then your patient's good. Just check the optimal amount of B12 for that patient. Make sure that for the optimal nutrition, the B12 needs to be somewhere between 550 to 600, 500 to 650, again, depending on if your patient has underlying chronic inflammation. So if patient has no methylation defect, if your patient's with a normal neurobium forte, which is also methylcyanocobalamin and not B9 along with it, if they're managing, that's good. But in those patients, always just for a sideline test, get a B9 test done, and if required, start them on folate individually rather than maybe giving B12 if it is normal for them. Because usually most tablets have very less amount of folate, maybe a 1 mcg or 10 mg to begin with, which is very small if we know that, it's not going to make any difference. So ideally, if no methylation defect, very good. B12 just maintain between the optimal ranges as your FLR shows.
I think she's incorporating you are incorporating B12 with the lipid profile, no?
Okay.
Yes.
Which part of the lipid profile are you talking about though?
See, cholesterol was high, triglycerides were high, and LDL was high. HDL was normal in a good range.
Triglyceride high is always correlated to insulin resistance. So there are patient most probably has insulin resistance. I'll tell you, today I had a patient in the morning only. The patient's HbA1c was somewhere around 5.1. We would think blood sugar is absolutely normal. When I checked the triglyceride, it was 241. When I checked the SGPT, SGOT, very elevated, more than 35 for both. Patient has estrogen dominance correlated with the insulin resistance, and the triglyceride was 241. So most of the times for insulin resistance, this patient's fasting insulin was 5 normally. So in these cases, maybe the postprandial insulin will increase. Doesn't mean this patient doesn't have insulin resistance. So the triglyceride is high because of insulin resistance. LDL high, again, if it was not more than 115, one go, that shouldn't be the primary concern, and optimizing the HDL should be the primary concern. But if triglyceride is your only concern, I would suggest look into and check more into insulin resistance. Okay. Okay. Yeah.
Yes,
Yeah, we'll
Madhuji,
take in
ask a
the
question.
yes.
You're already unmuted.
Hello.
Yes,
hello.
Madhuji.
Yeah. So mine is not a question. So just a suggestion. Just an input for Dr. Arvind. I just realized that you had mentioned your patient still is passing stool every other day. Not regularly. So did you? You have already mentioned about the microfiber part of it. So how about increasing the vitamin C in the morning, further, or maybe magnesium? Now you can start a little bit if his renal factors are not affected. And then in the fiber, microbiome fiber, probably that the partially hydrolyzed guar gum combination that works good. So if you can add modify something and try on him, this is just my suggestion that but that works with me. It has worked well. With
Actually,
him.
I think pooping after 1 day is normal.
Right.
Actually, I think pooping after 1 day is normal. Actually, I think pooping after 1 day is normal. Actually, I think pooping after 1 day is normal. Actually, I think pooping after 1 day is normal. Actually, I think pooping after 1 day is normal. Actually, I think pooping after 1 day is normal. Actually, I think pooping after 1 day is normal. Actually, I think pooping after 1 day is normal. Actually, I think pooping after 1 day is normal. Actually, I think pooping after 1 day is normal. Actually, I think pooping after 1 day is normal. Actually, I think pooping after 1 day is normal. Actually, I think pooping after 1 day is normal. Actually, I think pooping after 1 day is normal. Actually, I think pooping after 1 day is normal. Actually, I think pooping after 1 day is normal. Actually, I think pooping after 1 day is normal. Actually, I think pooping after
No, I don't think so.
I think so. I think so because on the diet he is having, pooping
It's a
once
very
on a ketogenic diet, it is very common.
But about the gut aspect, gut.
Nothing happens. The fiber is very low, and the food absorption, nutrient dense food is given. Food absorption is very good, so the leftover is very less. So after once a day is not a problem.
So if you look at his carbs also currently, Madhuji, it's very low exactly. So I think we were also discussing that once maybe the carb gradually, Dr. Arvind starts on increasing it, more fiber inside the diet might help this problem by itself only. Right now, the diet is also so restricted, and rather than, I would first want to prioritize on the diet. So I think we had this discussion as well, that including more fibrous foods, I think in terms of carbs would help further in the digestion as he goes forward with the food-related interventions.
I will increase some soluble fiber.
Something prokinetic like something vitamin C, increase that or.
This patient already is on vitamin C, I think,
5
Dr. Arvind,
grams.
right?
He's daily taking 5 grams of vitamin C.
All right. Okay. Thank you so much. So I think it has been a really, really interesting session. No doubt about it. Everyone really, really enjoyed. By the way, I want to see on the chat box, how was the session for all of you? I had sent a message across as well. There was a link wherein I had requested you for a feedback. So you can send in your feedbacks, by the way, on that link. So I'm just sending it across again. And you can put in your feedback over there. And in the meantime, yes, Dr. Arzu, what is it that you would like to tell everyone for all of this? What is it that you would like to give?
I think as a closing comment, I would say that it's actually very overwhelming and very good to have people like Dr. Arvind who have been coming up, taking complex cases, challenging enough, putting it up and doing it with so much confidence. Like I understand that, to get through the whole journey of unwinding the case is very difficult per se. But what we all need to learn in terms of functional medicine overall needs to be that it is building the block, connecting the body as a whole and thinking about it. And again, that is why it becomes very personalized because every block, every connection in the body could be very different for sure. So I would say, I think amazing on Dr. Arvind. And I would say that functional medicine is what we're hoping and what we want to grow. We want to make the community bigger. We want to help in more people. So I think that's the goal for us as Vita One. And I think everyone, I would invite you to keep doing this activity further. It actually changes your approach on how you see the cases or maybe how you see this. So multiple discussions with Dr. Arvind over 1 month have made me also realize certain things. He's also gone back with me, gone back with certain things. So I would urge people, the alumni especially, to please come up because it's a great opportunity for you to do this, how we used to do it in our colleges. And it will boost up the confidence for you and your practice also. And again, give us a chance to connect and speak and spread your word and knowledge as well. So I think that would be me.
That's fantastic. And by the way, star of the day, obviously spotlight goes to Dr. Arvind. So yeah, if you want to have a photograph with the star of the day, then please switch on your videos. I think that's the only way that I can take your pic. So please switch on your videos. I'll be putting on social media, and I want you also to be on social media. Okay. So yes, stop typing on the chat box. Come on the screen. Switch on your videos. Switch on your videos. Switch on your videos. If you want to be with Dr. Arvind, then of course, what would we love to give Dr. Arvind? We would love to give a victory sign to Dr. Arvind for being so victorious with the patient and keep doing the good work that you're doing. Let's give a victory sign to Dr. Arvind. Switch on your videos, Dr. Krishna, Harshini, Jay, Srinivas, Surinder. Everyone, please just smile there. I'm taking the pic. I'll tell you when I take a pic. So girls are good at that. Okay. They say when they're taking a pic. Smile, please. 3, 2, 1. Yeah, I've got the first screenshot. Now, this is a very funny thing. I have to keep going one by one. I really wonder.
I think you'll have to do it one more. I can see a lot of people with their.
Yeah, just hold on. I'm just going to remove the non-video participants. Okay, I think some of them are coming. Okay, some of them are correcting their hair. Okay, sorry, I didn't give you time. Okay, okay, let's give that again. That victory sign. Smile, everyone. Smile, everyone. 3, 2, 1. and go. Yes. Lovely, lovely. Thank you so much. I've got all the people, as many as possible. Thank you so much for being there. We love our FMCN students. We want to see you keep growing, keep doing the fabulous work you're doing. Get in touch with each other, okay? I can't organize 24 hours webinars. You need to get in touch with your friends. Make buddies. That is a joking side, but yes. And if you have not been a part of the FMCN course, you need to be a part. You're missing out on a lot of stuff. We've got buddies here. We've got a lot of solutions, and we all are helping each other grow. We have a fabulous community. And if you are thinking to join the FMCN course, what are you waiting for? Contact Asma. She's on the screen right now, obviously, and just let her know and she'll get back to you. Thank you so much for the wonderful session. And yes, go grab your dinner or whatever you have to have. Have a wonderful night. Have a good sleep. Thank you so much, Dr. Arzu, once again. And Dr. Arvind, keep
Thank you.
rocking as always. Thank you so much. Sat Sri
Thank
Akal
you.
ji.
Thank you so much.
Thank you. Bye-bye, everyone.
Thank you.